Hello, everyone. Thank you for joining us for today's webinar, Is Fee-for-Service Compatible with Comprehensive Primary Care? I'm Todd Didier, Senior Communications Manager at the Primary Care Collaborative. For those of you who might not be familiar with the Primary Care Collaborative, the PCC is the leading national, nonpartisan, and multi-stakeholder voice advocating for better health for all Americans by strengthening primary care. The PCC unifies and engages diverse stakeholders in promoting policies and sharing best practices that encourage the growth of comprehensive primary care. As part of those efforts, the PCC hosts monthly webinars exploring important topics related to primary care, including today's timely conversation on how we pay for primary care and Medicare. But before we jump into today's conversation, I do have a few housekeeping items. Please note that all attendees have been muted and attendees' cameras have been disabled. As part of this webinar, we will be doing a 10-minute Q&A session at the end of the conversation, but please feel free to submit all of your questions at any time throughout the full run of the webinar. You should see a Q&A tool at the bottom of your screen that you can use to submit questions. Also, please keep an eye on the chat where our team will be dropping links to useful and helpful resources that are relevant to the conversation that we're having today. Finally, this webinar is being recorded and will be available for viewing within the next 24 to 48 hours. PCC will be sending attendees a follow-up email with a link to the recording and other helpful supporting materials. If you don't receive that email for some reason, you can find this webinar and all of our past webinars on PCC's website, thepcc.org. Now, with that, I'm happy to turn to today's conversation and introduce our moderator, Peter Long. Peter is the Executive Vice President for Strategy and Health Solutions at Blue Shield of California, a nonprofit health plan with over $24 billion in annual revenue, serving over 48 million members in the state's commercial, individual, and government markets. Long is responsible for strategies to achieve the health plan's vision of creating a healthcare system that is worthy of families and friends and is sustainably affordable. Peter is also a member of the PCC's board of directors, and we are thrilled to welcome him here today. Peter, with that, I'll go ahead and turn it over to you.
Great. Thank you very much, Todd, and welcome to everyone to this important conversation. I think we're raising this with a central question today that we'll be exploring, building on the recent hearing from the Senate Finance Committee about fee-for-service payments in Medicare, traditional Medicare, and how they work, do or do not support comprehensive primary care, but gets at this more central issue of the relationship of paying fee-for-service, so fee for every service of healthcare provided, and how does it match or not match with primary care. For context, we're using Barbara Starfield just to level set. We'll use Barbara Starfield's 4 C's, comprehensive care, first contact, coordination, and continuity. Obviously, we know primary care comes in many different flavors and sizes and approaches, but we'll use the Starfield as a shorthand today to orient us around what represents high-quality primary care. We've got a number of topics that we're going to talk through today. One is what is the fee schedule? So first, understanding what is the Medicare fee schedule. One of the things I've observed as working for a private payer is that the Medicare fee schedule's influence extends beyond just what gets paid for services for Medicare beneficiaries. It also influences the private sector, other lines of business for private health insurers, and also for Medicaid programs. It often becomes a reference point for much of payment in the industry, and even a reference point for many of the value-based payment models that we're going to talk about today. We're going to talk then about what are some of the shortcomings of that fee schedule. So what are some of the challenges by adopting it and using that? And then we'll move on to some solutions. So what changes are needed to shift from a fragmented care for seniors that they're receiving today, particularly those with chronic conditions, to what would it look like if they received continuous high-quality care? And then we'll explore, we've got some great experts on the panel. We'll explore how hybrid payments can enable that shift. And then finally, that value-based payments, so how can those payments work within the fee schedule? So we're really excited at Blue Shield. We've been doing a lot of work in my role about how do you bring more value-based payments into primary care. We've actually used some of Amal's work in one of his roles to take the National Academy of Medicine's hybrid model. We call it primary care reimagined. So how do you pay for primary care partially capitated, but then also using fee-for-service for those things that we want to happen frequently, like immunizations and well care. But that's also putting together performance bonuses, not just for quality, but also for member and patient satisfaction. So we've been deep at work at Blue Shield in doing this, and also trying to bring together other health plans on a voluntary basis for aligning the sector around value-based payment for primary care more broadly. We'll be launching a multi-payer pilot in California later this year, and are super excited to see the results. If we can align as health plans on what good quality care looks like, and how do you pay for it, and how do you measure it, how do we actually drive that work? Will that increase the quality of care delivered by primary care practices? So we're, as I said, super excited and super deeply involved in this topic. So with that, let me introduce our panelists and start our conversation with you all today. So first we have Dr. Amol Navath from University of Pennsylvania. He is the founding director of the Parity Center. He's a professor at Penn and also works at the Veterans Affairs Administration there. So we'll hear from Amol. Then we'll hear from Melanie Matthews, who is the president and chief officer of PSW and the president of Multi-Care Connected, and has spent nearly 3 decades driving value-based care work for primary care, and thinking through how do you drive this towards in practice. And finally, Christina Bocuti she's vice president of health security at AARP Public Policy Institute, and has deep expertise and knowledge, and lives every day how do you drive and inform public policy to deliver better primary care. So welcome to our panelists. Super excited for our conversation today. Amal, we're going to start with, Christina, we're going to start with you, and actually level set for us about the Medicare fee schedule. There was a recent hearing, as I mentioned, in the Senate Finance Committee about questioning the Medicare fee schedule, and does it help or inhibit delivering comprehensive primary care to seniors. And so before we get started, if you could take a minute and talk us through what that Medicare fee schedule is, how it was derived, and how it's used, that would really help us to get started. So I'll turn it over to you.
Sure, I'm happy to. Hope I'm on. I can see. Try to see. Okay. Yes, when you asked me just to give a little level set on what is the fee schedule, it was hard not to think back to my days when I was a staffer on MedPAC. So I'm gonna try. I might be a little rusty, but I'll try and give the lowdown on it as quickly as I can. Essentially, the fee schedule is about a list of services, I think about 8,000 by last count, of services that can be provided by certain health professionals. They range from office visits, surgical procedures, diagnostic tests like imaging, for example, and therapeutic services. And so on the fee schedule for each service, the fee schedule details like several components that are used to determine how much Medicare pays for the service in traditional Medicare. So I'll say just one detail, some small details here, is that you sum up these factors and you get what's called relative value units. So you might have heard of the RVUs. And so for each service, these RVUs estimate costs and other expenses that the office takes on to produce the services. And then that gets summed up and converted using a conversion factor to a payment amount, a total dollars. So that's about as complicated as I'm going to get on that piece of it. But of course, I can expand more if we want. And keep in mind, typically Medicare pays 80% of what's called the allowed charge, and the beneficiary is responsible for the remaining 20%. If the beneficiary has supplemental coverage, such as Medicaid, or they've purchased a Medigap policy, their co-insurance is likely covered. And then the types of providers who can bill from this fee schedule include physicians, nurse practitioners, physician assistants, and other clinicians. I'll mention just a couple other notes regarding chronic conditions in particular, which I think is the the topic we're talking about today. So most of these services are really for discrete face-to-face encounters, meaning that the patient has some interaction with the clinician or the clinician staff, and those include some small degree of follow-up, like ordering a prescription, something like that, calling the pharmacy. But that's really the follow-up that's included with just that one service. And now, as I think we'll talk about further with others on the panel, the fee schedule does have separately billable chronic care management codes. And those are meant to account for more non-face-to-face care that's in between visits. So we need to distinguish sort of the difference between a little bit of follow-up on these services and chronic care management, which is more extensive between these encounters. And this is something I hope we'll talk about more. I think that's enough for this low level, this level set. But if there's any questions, I'm happy to keep at it.
So one question for you. Thank you. That's actually super helpful. Before we turn it to Amal to talk about what the intersection is, what's the point of the fee schedule? So like at a highest level, if we're thinking traditional Medicare, why do we need a fee schedule to start with? Just because I think there was a rationale for it, and it feels like listening that we've built on chronic condition add-ons. Well, here I think about additional codes and things like that. But if you could just, what's the point of having in a traditional Medicare, what's the point of having a standardized fee schedule?
Well, it converts to the payment. So you have all the services and they convert individually to payments. So, in fact, in the little photo, kind of, I imagine is something somebody looks up, you have the looking up, here's what we did, and this is how much Medicare is going to pay for it. Now, I think what it evolved from when there was a fee for service, and it evolved from private payment. I guess I would ask you, like, there's fee schedules in other areas.
No, sure, yeah. It wasn't a trick question. I just was saying it had a purpose at the beginning. So I'm not trying to, so I just want to, for everyone that, because sometimes
I'm afraid I'm not getting at what you're asking, but
so literally
essentially
the point of it was standardizing across the country so that we could know for X type of work done, that we could say it's worth this much, and we will then convert activity into payment. So, sometimes I think I just wanted to, sometimes we're going to talk about all the limitations for the fee for service. It actually did play a role, particularly when we're predominantly paying providers for a set of services and converted those activity into money, right? Like, that's like the most basic thing. And then
I
we
get what you're
added a
saying.
lot of stuff onto it. So, but Amal, let's now figure out what's wrong with it, or how could we improve it, particularly for those folks, or, let's just start with what are the challenges, particularly for seniors with chronic conditions.
So so you're asking me or Amal, right?
Yeah, we can come to you first. Let's start with him, and then we'll come back to you, Christina.
Sure. Yeah. So the challenges for seniors with chronic conditions, fundamentally, there's a lot of complexity, right? So most of our, for example, Medicare beneficiaries have multiple conditions. Many, over 15% have 6 or more conditions. And that's a lot of complexity to manage. There's not only the prescriptions that you're trying to take on time, but also getting to the appointments, et cetera, et cetera. And so the way that I kind of think about this is essentially the chief challenge is fragmentation in our system. It's not like they have one clear quarterback who has a confluent view of everything, has perfect information and transfer information between specialties and facilities and hospitals and the like. And navigating that complex system it's really hard to get optimal health coming out of it. And so I think, Peter, thanks so much for the question. I think that's kind of, to me, that becomes the biggest challenge for our Medicare beneficiaries or individuals with a lot of chronic conditions.
So it's the fragmentation, and that by having this payment system, it just increases the fragmentation because folks are getting paid not for coordinating, but actually for each service provider, regardless of whether it's coordinated or not. So we're reinforcing fragmentation rather than addressing it.
Absolutely. It comes right back to the point that you were just making earlier, which is we have this activity-based system. And so in some sense, we get paid for activities. I myself am a general internist, so I get paid for the activities that I do. it turns out that to do really effective, well-coordinated primary care, there's a lot of activities that we have to do that don't show up on the fee schedule. And if we try to get them to show up on the fee schedule, which Medicare has tried to do in part over the past several years, you get a very administratively complex set of codes where, I call it a kind of ticky-tack death by a million codes kind of situation, where you get this situation where oftentimes billing for a particular code is more costly than the reimbursement that a PCP would get for doing that. So the activity-based system certainly is a problem in standing up and propelling this fragmented system.
So let's bring Melanie, the CEO of PSW, into the conversation, who's been at this for quite a while, delivering this on the front line. So Melanie, as Amal just said, CMS has been adding new code, right? And in fact, Christina talked about that we started with a base set in the fee-for-service model, have been adding code. The reality is they've been underutilized, right? So that, and I think Amal began to touch on that, but if you could expand on, it isn't as if CMS hasn't been adding new codes, hasn't been contemplating that care is fragmented. What's your assessment of that process and how it's going, and what are some of the challenges there?
Sure. Thank you, Peter. So for one, I would say that in the vantage point that I come from is the sort of early adoption related to the advanced alternative payment model programs that were launched following the Affordable Care Act with the development of the Center for Medicare and Medicaid Innovation. And in those models, predating some of these additional chronic care codes that are coming out in the fee-for-service model, our entire infrastructure was based on identifying those patients that Amal beneficiaries just referred to with 6 or more chronic conditions, and wrapping around services with care coordination and support, addressing social determinants of health, addressing transportation, med delivery, the social infrastructure and support services that are needed to help manage the clinical conditions of care. And those have been predominantly provided without a billing code because you're at risk for the total cost of care related to a benchmark. Therefore, you're sort of incentivized to provide the care coordination needed to improve the quality and reduce the cost of beneficiaries. I would say that the idea and the model related to increasing codes for those kinds of conditions, I applaud the effort in terms of, I think it's time that we think about how we change the financial mechanisms that support our Medicare infrastructure, because Medicare paves the way, Peter, for all sorts of codes and structures that occur throughout the ecosystem of the payers and the delivery system sort of across the board. So I would just sort of double down that I think that they're necessary, but I think that in the accountable care models, we have the unique opportunity to provide those services with or without a billing code to ensure that we're meeting the needs of the patients and the beneficiaries, and really supporting the provider for additional services that can help manage the population. So that to me is really critical for our moving forward. I would also just add that, sorry, Peter, but I would just add one more thing, which is that in the accountable care organization, we are paying hybrid capitation to providers on a subset of codes. And so we feel that the primary care capitation payments fit very nicely, both in accountable care organizations, as well as we move forward investing that methodology and new payment models and approaches.
So basically, it's incompatible, right? In some sense, that the way forward is the way you have designed your organization to deliver healthcare, deliver primary care, is set up in a certain way to get paid in a certain way to give you flexibility. And no matter how many codes we have on the other side, they're just not compatible. I mean, is that really ultimately what you're saying? And you don't want to change the way you practice medicine or the teams practice medicine. You'd rather have them get paid in a way that facilitates the way you've organized yourselves. Is that the bottom line, in a sense that there's that mismatch?
Yeah, I would say that I feel like the end result we want to get to is capitation. I think primary care is the backbone for value-based care, and ensuring that they're focusing on the patient relationship and needs. There are so many codes, and it's very complex, as Christina outlined. And I think that we're moving towards the ability to provide capitation across the system.
So Christina, let's talk about patients now. So your role at AARP, what is the barriers that stand in the way of effective care, and particularly prevention, right, and preventive care for beneficiaries in traditional Medicare, and then with an emphasis on those with lower incomes. So what are the implications? So Melanie was talking about it for providers and how they organize themselves. What are the implications for patients?
Good questions. I think effective chronic care management, the first thing that comes to mind is a barrier is just how hard it is. And I think I'm always talking about, it is really hard. And, it involves lots of feedback between the patient and the clinician. There's constant ongoing monitoring by its very nature with chronic conditions. And so I would say that capturing that is a challenge in and of itself, sort of to account for. And the fee schedule complications are sort of go hand in hand with that challenge. I would say you asked about other barriers. It's important to also note that chronic care sort of can't assume that patients leave the office and are able to do everything that has been recommended and indicated. So there's a serious role for caregiving that I think we should recognize that role when we're talking about chronic care management, and kind of the tasks that the caregivers have to do, the discussions with them, and where does that fit into chronic care management, and how's that accounted for? And then some people don't have caregivers. So that's another problem with effective care management, when that's sort of part of the equation and it's not really there. And you asked about low income. I would say certainly people with chronic conditions, they have high out-of-pocket costs. By definition, they are generally have more appointments, are taking more medications, they have higher rates of hospitalization. And that makes affording all those things, more difficult on top of all the other household expenses. So they are presenting issues. Keeping in mind that there's about 3 million beneficiaries in traditional Medicare who don't have supplemental coverage. So they're fully exposed to the out-of-pocket co-insurance and deductibles. Of course, people in Medicare Advantage also can have cost sharing. I'm not saying that they don't, but those are things to keep in mind if we're thinking about adding on. And that's just what Medicare covers. There are other items that aren't covered. And then there's social risk factors with chronic conditions that exacerbate the affordability problems. There's lots of evidence on racial and ethnic disparities in the prevalence of chronic conditions. So these are all certainly considerations for effective care management. And I think that part of this discussion is going to be, where is effective care management just better care? And where are we talking about it as savings? So I think, I don't know that they both have, that the savings has to happen all the, we can recognize that better care is better care and the patients deserve that. And that's sort of coordinated, thoughtful care. So we can consider when we shift, as you said, in other payment models where that fits in. Was I able to answer some of your question? I think in part, anyway,
No,
thinking about the
yeah.
patient, of course.
Yeah, no, I think it's comprehensive challenges. I think you've all laid out both for Amal from a design perspective, right, and how we're thinking about it. Melanie, for you from the provider's perspective, and Christina, for you from the patient's perspective. It's not working. So let's shift gears. So we always like to bring people right into the issue with us, and let's shift gears and talk about solutions. So in 2021, CMS said that all beneficiaries in traditional Medicare should be in accountable care relationships by 2030. And we're getting close, right? We're halfway through the decade. And there's strong evidence that provider-led accountable care organizations provide higher quality care, oftentimes more cost-effective. And so let's think about traditional Medicare, accountable care organizations. How do we begin to think through and bridge that divide? Because we've laid out a number of I would call them disconnects between the fee-for-service schedule as it exists today, even with add-ons, even with evolution and even with evolution and add-ons over time. But so I want to turn to you, Amal, and begin to lay out some opportunities. And I think maybe starting with, how do we reconcile different kind of hybrid pay-for-value type models and understand what's that bridge from a system that we think is probably not that well connected, not working that well today for the needs, as Senator Wyden and others have said, to something that, what's that bridge to the future? What's that bridge to solutions? So if you could walk us through some of that. I know you've helped us and other Blues plans do it. So look forward to your counsel.
Sure. Thank you so much, Peter, for the question and the opportunity. So, I think, fundamentally, I think that the challenge, as I mentioned, is fragmentation. Peter, you very appropriately highlighted, we have a whole milieu now. We have an ecosystem of different types of value-based models that are trying to get to accountability, trying to get to higher value care, trying to get to more systematic care. And while many of those principles do apply at the primary care level, I think one of the key distinctions to think about is, one, a lot more care in some sense for a PCP, for a primary care physician or practitioner, is in some sense happening off the fee schedule, right? There's a lot of good primary care, includes a variety of different activities that just don't get paid in an activity-based system, even as we've added more and more codes. The second piece that I think is fundamentally important that I would want to highlight here is getting really great primary care does not need to involve financial risk. At the end of the day, primary care in Medicare terms accounts for something like 4% of overall spending. I think estimates across the country range somewhere between around 3 to 4% at the low end, maybe up to about a max of 8% in some private payer settings. Really, really extreme spending for primary care would maybe be 10% of overall spend. So we're not trying to save the system by cutting that 4%, right? That doesn't make sense. In fact, we're trying to empower the primary care system and harness more of its influence as a way to generate savings from unwanted care, preventable care across the other parts of the system, while providing sustainability, flexibility at the practice level for primary care physicians. So one of the concepts that has developed, I would say somewhat organically, but maybe it's finding its moment right now, is this notion of hybrid payment. And basically what hybrid payment does is it's kind of like a value-based payment model for primary care, again, noting that financial risk is not a very important component. And it basically says, look, we're going to pay the lion's share, somewhere around half or more of payments will be paid on a per patient per month. So per beneficiary per month, or in the commercial sector, maybe per member per month, fixed payment, consistent payment that can be risk adjusted. And that provides sustainability, that provides stability. It provides compensation also for those activities that are not happening during a visit. It also, because it's linked to a member or a patient, it allows a view outside of a visit-based world, and one in which we can think about staffing in a different way. The other part of the payment model, so there's the per member per month portion, there's a continued portion that gets paid fee for service. And the reason for that is because there are many activities that we want PCP practices to continue to get rewarded for doing more or doing a lot of. That's things like immunizations or types of procedures that might otherwise leak out to a specialist. So think about simple dermatologic procedures, perhaps joint injections. And then in red here, I'm in the top left corner of this slide, there's this question of whether we should also include this partial fee-for-service piece, which is basically a smaller amount, not a full fee-for-service payment amount, for evaluation and management visits. And the reason for that basically is to preserve access and to acknowledge that providing visits is actually costly for primary care practices. So we don't want to penalize them for better access. In fact, we want to reward them and make sure we're offsetting those costs. So that's the structure of this hybrid payment model. Last kind of 2 points that I'll make. One, again, it's not a new idea per se. You'll see that Medicare has been testing different versions, kind of a stepwise journey to get more toward this type of hybrid payment model that I'm describing today. And then I've been working with a number of Blues plans, as Peter mentioned, did some work with the Blue Shield of California earlier, and then have had a long-term collaboration with the Blue Cross Blue Shield of Hawaii, or HMSA, where we've rigorously tested and expanded these models over the past decade. So the benefits of these models, I think I've touched on several of them. I would say that there is good evidence that they do provide stability. They allow flexibility for practices. In fact, we've seen a greater uptake, for example, of telehealth that predated the pandemic. And in one of the best benefits, for example, in Hawaii, when the pandemic came around, there was no primary care crisis because we were already in a system that was sustainable, that wasn't dependent on visit volume. So with that, Peter, I'll turn it back to you.
Great, thank you. And I can attest at Blue Shield of California, we've actually seen really promising early results with the hybrid payment model, and it had through COVID, I think, right, stabilizing these practices. So maybe get Christina and Melanie, your reaction to the hybrid models and how you're seeing those, and then we'll switch to talk about what Congress and CMS can do. But first, just get your reaction to the shift from what we were talking about, Christina, what you presented to what just Amal just presented. What's your sense of that in terms of directionally? What are the opportunities for providers, Melanie, for you, and for patients, Christina? So, and then, as I said, we'll shift to what public policy we can change and how we can kind of implement some of this. But first, just to hear your reactions.
I guess I'll go ahead and get started. So as what Amal laid out is exactly what we've been advocating for, and in the notion that Amal brought up related to the primary care crisis being less significant when there was the stable and consistent income during the pandemic for primary care. We found the same outcome as it related to our primary care, both for Medicare Advantage and other plans that we take for value-based arrangements, that we were able to continue to pre-fund in a hybrid type of approach to primary care, which is very helpful. The other piece that I just wanted to say as a little plug for accountable care as it relates to the patient that Christina was speaking of, was that in the accountable care, we're able to implement through Medicare waivers for cost sharing. So for chronic care management, the 80-20 rule that Christina was talking about, where Medicare pays 80% and the copay or MedSup pays the additional 20%. I just appreciate that in the waivers related to the accountable care models, we can implement a chronic care waiver of the cost share, meaning that the beneficiary doesn't have to pay out of pocket for those chronic care services. So I would just say that the flexibilities in the models, as we're testing new ways of paying for care, should influence not just the providers, the physicians, but also have a positive benefit impact to the patients and their copays. So I just thought I'd share that.
That's helpful to hear, Melanie. I would say that it's great to consider the hybrid models, and to the extent that primary care providers want them and it helps them stay in the workforce, that's going to help patients because we know that patients want to be able to keep their providers, especially the ones that are managing their chronic disease. And so I think that's an important component of this consideration. And I also welcome hearing about ways that it's not adding to patients' out-of-pocket costs. And I think that's an important consideration too. So it's, we keep thinking about ways that people who are not in Medicare Advantage are the patients and the providers that are providing services to patients that aren't in Medicare Advantage. What ways can traditional Medicare evolve to be more receptive to the trends of providing better care? And care management is a big piece of that. So I'm very interested in hearing ways that it makes care better for patients.
Perfect segue. Thank you. You're setting me up here. So let's now shift gears and say, we have advice to Congress, right? So Congress held a hearing. Several of you were actually on the panel. What could Congress do? And I don't want to just limit us to payment models. I think we spent a lot of time on it. That's important. And we're looking at the fee for schedule. But I think, Christina, you opened up care models, right? Or care management or other things like that. So obviously we'll start with accountable care models and look at those, or value-based payment. But I would open it up too if there are other things. I think you hit on it, Christina, which is how do we have traditional Medicare, which is built on this fee-for-service chassis? How do we make it perform in a way that provides better outcomes, right? And things like that. So let's open it up to both CMS and Congress. What advice would you give them? How can they improve care for chronically ill seniors or seniors with chronic conditions?
Well, I suppose I will start here, Peter, and I would say that one of the things that I have as a recommendation is to continue the investment into the AAPM bonus, which allows an incentive for providers to jump on board with joy into alternative payment approaches. I think that change is hard, and moving the fee-for-service chassis to a hybrid capitation and overall living within a benchmark to manage care and ensuring that we have high performing networks and communities of providers that work together. I think more now than ever, coming out of the pandemic, we've had a lot of issues related to access and a lot of burnout at the clinician level. And I think we need to look at other ways to provide support services that wrap around the patient. And I believe strongly that investing in the AAPM helps that movement. Medicare ACOs have saved $22 billion over the last 10 years, so it helps to benefit the trust fund. But most importantly, and coming from the medically related social service background that I sit from, we have, as Amal indicated, a very fragmented system. And I think as we think about using an accountable care approach and hybrid capitation, those are levers that help us move forward at designing a healthcare to provide better outcomes.
Yeah, I'm happy to chime in here as well. And I would say definitely very much agree with Melanie's comments. I think doubling down or continuing to promote alternative payment models certainly is one of the core strategies. It's interesting to see how technology may enable some more flexibilities down the road. And I don't mean just telehealth or something like, or RPM. What I mean here is, can technology actually unshackle us eventually from this fee-for-service system, where we have this bill code kind of situation? And the challenge there is, even if we have an accountable care organization type model or an episode-based model where we're incentivizing at an overall kind of umbrella level of an episode or a population year, if every activity is still being billed and thought of at an individual activity level, can we really get enough of a mind shift? I think to some extent the answer is, well, we seem to have made some progress in that direction. Melanie highlighted some of the savings in MSSP. I think there's other examples of successes. But if we really want to get the system to shift over, then we do need to get away from this fee-for-service chassis, the fee-for-service mentality. I think PMPM-based models like the hybrid payments are a step in that direction. I wouldn't say, gosh, they're everything that we need. That's the solution. We're done. Let's call it a wrap. But I think they are a step in that direction. And hopefully we can get other adjuncts like technology, et cetera, to really shift us over where we're thinking about managing care, delivering the care model that Christina cares so fundamentally about, getting the outcome for the patient and the experience in a way that makes sense to them, right? Like if you think about a patient right now, they want better care. They want better outcomes for my diabetes. I want to breathe better if I have COPD. I don't really care if I'm getting a pulmonary function test or this inhaler or that inhaler. I want to breathe better. So if we can really deliver a care model that is financed in a way that meets the patient where they are, then I think we're really humming. And I think that's where technology, payment, care model, all these things have to come together over the next several years to get there.
Christina, you're advising Congress and CMS. How can we improve traditional fee-for-service Medicare?
Well, I'd like to hear more on how to address what has and hasn't been learned from the models that CMMI has had. And And I actually was hoping to hear from that. And I think what it feels like that's there are pieces of what's being discussed here in the hybrid model that are being tested, but there are probably explanations for how it has and hasn't worked, you know, what's worked well and what hasn't. And so it might be helpful to hear going forward what would be different. And that will help. I also certainly want, you know, and what's being described, always have on my mind affordability for the patient. And I think, you know, you're right, the patient cares about how much their ability to breathe with COPD and that, and also afford to be able to get the care that they need. So I don't want, is it okay if we hear a little bit about what we've learned and what go forward? But Peter, I don't want to take away
No.
but I think that's helpful because those are the messages that I think our policymakers are hearing.
And they're a great pivot to, we have a piloting system, right? Or a market test, we would call it, but is one. But no, as a health services researcher by training, the last three comments were near and dear to my heart, which is the system matters, how we pay for it, and then our outcome measures are super important. So my heart is, you know, growing 3 sizes today based on thinking as a health services researcher. So either Amal or Melanie, do you want to spend a minute or two? Because it actually transitions very much into, we've got a lot of great questions. So why don't we respond, Melanie, Amal, if you could just give a high level of what you think we've learned from the CMMI endeavors into this at a high level. You don't need to, we'll put links in and we can go through that. And then we'll pivot because as I said, we've got a lot of really good questions coming in from the audience.
Sure, I can start. I'll try to be brief here because I know we have a lot of audience questions. So I'd say two key things I'd highlight. You know, number one is feasibility. You know, we've shown that a variety of these different type of models, including the advanced primary care or hybrid primary care payment models, can work in multi-payer ways at scale. I think that's kind of key thing number one. Number two, I think we've also learned on the flip side of that is Medicare doing this by itself doesn't get to enough of a tipping point for practices to really justify the full investment that they can make to unlock all this, you know, potential energy that could be harnessed. That, what I mean by that is different staffing, different use of technology, different use of things like telehealth visits to really meet patients where they are. Very hard to do that in a piecemeal way. Melanie, to you.
Yeah, thank you. The only thing that I would add was that I think a great learnings is how much data matters, and how much data allows us to identify sort of the needle in the haystack for the patients that might be getting lost in the system that could utilize different resources. I will share that we've used data to look at hotspots of patients with, where we call them, you know, we use the area deprivation index and other kind of models related to zip coding and hotspotting for areas where there may be healthcare access deserts, as well as an aggregation of complex care patients that may not be able to get the visits and the support that they need. We use that data to build a new clinic specifically to address those patients that are have chronic conditions and need additional supports. By being in alternative payment models, it allows us to make those investments into the infrastructure for things like registered dietitian, behavioral health, care navigators, a panel size of 1 to 500 per provider instead of closer to the 2,500 we see in a traditional practice under a fee-for-service model. So it's allowed us to test out different care delivery models and sort of segment to address those that need the care. And that's really necessary by having the data, or it's a necessity is having the data to help us identify those pieces, those areas and those beneficiaries that most need the support. And then the last thing I'd say is that we had some chronic care incentives through some of the ACO models that allowed us to identify patients that better control their hemoglobin A1C, and if they were able to achieve that, we were able to give a coordination award directly to the beneficiary, and really ensuring that we're engaging the patients in their care. We don't always know what's best. Sometimes the patient knows what's best, and when we can work together and define new ways of incentivizing and engaging patients in their care, I think that's really important lesson learned, and that's one of the features and flexibilities in some of the accountable care models.
Great, thank you. So that transition, we're going to transition to the audience because, as I said, we've got a lot of great questions here. I'm going to try to mix them up. So if we don't get to all of them, I think we'll have a process. I'll work with Todd to make sure we follow up. But let's jump to it. The first is an interesting one about economic incentives. Maybe I'll start with you, Amal, and both you and Melanie answer this one. So how do you address the risk if primary care providers are paid more per patient, right? So if their revenue goes up, that they'll actually see fewer patients and will actually exacerbate the shortage or access problems that we're experiencing in the country in different regions. So how does, just respond to that economic incentive, I think, question, and also probably provider behavior.
Yeah, it's a great question. So, I would say that the general realized experience on this has been that actually unlocking or unshackling PCPs from a visit-based fee-for-service system actually allows them to more effectively care for individuals, and at times more individuals, especially if they staff differently as a team. And so for a given unit time, they're actually more productive. So I think what we haven't seen is PCP saying, oh gosh, I get paid in a different way, or I get paid maybe more per patient, so I don't need to see as many patients. We actually have seen, if anything, the opposite trend, which is to say, hey, I'm paid to manage people, not do just visits with them, and I can share some of that load with other APRNs or other clinicians, and so I can more effectively manage a population. So that's been more of the experience. I think from an economic incentive perspective, especially if we get these partial fee-for-service visit rates right for E&M visits, we should actually make clinicians essentially indifferent. They should want to do the visit when it's the right thing clinically, and they should not feel like they have to do a visit. If the right thing is to do something via telehealth or phone or something else, they can do that as well. So I think there are ways to get the economic incentives right. And thankfully, maybe this is all intrinsic motivation of clinicians. When you give them more flexibility, we haven't seen that the pendulum swings back and they shrink down and they stop seeing people.
Anything to add, Melanie, or no? We can go to the next question is about maybe it's a little bit more about the model, because it's interesting. This question resonates for me about how does it work with you're blending the things you want to have, be efficient one or economically efficient with a hybrid payment or a per member per month payment. And then the other parts, in some models it's 50-50, in other models it's different, or on fee for service, that does send a mixed economic model, a mixed economic message, right? Or mixed incentive messages. And how have you found in practice, I would say both to Melanie and to Amal, how do you find in practice that works? And can the practitioner hold that information if there are certain things we want to be efficient with and get paid on a per member per month, and there are certain things we want to have happen? Does that work in the real world, I think is what the question is. And how does it, linking both of those to quality outcomes?
So I'll let Melanie take some of the kind of practical clinician level things. I'll just say, from a policy design perspective, whether it's Medicare or whether you're a Blues plan or a local payer or otherwise, I think part of the goal actually is to have that mixed incentive, because guess what? Anytime we're in one homogeneous system, the unintended incentive that we have ends up kind of rearing its head in a more fulsome way. So what do I mean by that? If we're in a full capitated model where we don't have this fee for service piece of it, then things like the concern that our prior question asker had, which is, what about access? We worry about access in a full capitated model, just like we worry about fragmentation and lack of coordination, lack of flexibility in the care model in a pure fee-for-service system. So what we are kind of trying here is to have our cake and eat it too, by balancing both the good and the unintended incentives across these models. And Melanie, I'll let you take it and talk about your experience on how to make it work on the ground.
Yeah, I would just say that in the the combination of the models. I think when Amal brought up earlier, the primary care may refer to a specialist care that could occur in the primary care setting, is that because primary care panels are so overflowing, there tends to be more of a referral to the specialty than when they have a smaller panel and can more comprehensively care for the patients. So when I talk to the providers, what I hear is, I'd rather take care of less patients and do it really well than just be triaged into specialty. And I think that that's our design and our staffing and sort of workforce has really compounded that issue. And so I would say that there's an opportunity to look at it another way and ensure that we have smaller panels and can allow the primary care to really do all of the management that they're capable of accomplishing.
It's always struck me when I, think about the model, is that it's more trusting of the provider to do what's best for the patient, in the sense that, well, I'm not gonna get any, it's basically meeting my cost if I bring the patient in for the procedure, but so I'll do that when it's really needed. And it's important. It's not, there are times when patients are coming in just because of the bill, of the ability to bill, when it's really not needed. And sometimes it's very hard for a patient to get to the office. But the truth of the matter was that for the provider, that was the only way to be able to create a bill scenario. So this is sort of creating the instance where the provider is bringing them in when they really need to, and doing the other work behind the scenes when they don't need to come in, but they still need consultation and discussion. And there's a lot of trust there. And I think that's something that we have to come to grips with. There's a lot of trust that the provider is doing, making these choices and decisions that are best for the patient and best for the, financial viability of the practice too.
No, I think that's right. And trust is a word we probably don't talk enough about in healthcare. So we'll do two more questions, I think, to bring all three of you in. One is around what's the impact of these approaches to population health? And Christina, I had for you, why is that important? So thinking about, like, we've been talking about individual patients, seeing that and payment for either services or managing a panel of patients. What are the impacts on population health management? We'll start with you, Christian, on this one. And why is that important to actually be able to do population health management?
I have to think about that. Years and years ago, I remember hearing about practices that could not tell you how many patients had diabetes, right? And I think this is improved with a lot of the education that we have now. But I think understanding all your patient, the work that you're doing, you can think about your whole patient panel. This gives you that opportunity and to think more about everybody with chronic conditions, right? Like that you're moving towards that. So I think of that as a population-based health for the provider's patient care. But I also think of population-based health even broader, which is in the whole community, whether they're seeing the provider or not. So, but I think what you're referring to is more population health for the set of patients for the primary care provider's caseload. Is that what you're thinking? Like when you're getting the yeah. I mean, it on its face, it makes so much sense, right? And it's sort of getting down to how it happens and the execution of it in a fair and equitable and a good way. So I think those are just considerations about that. I hope I'm answering your question on population. Okay.
Others want to, Amal or Melanie, about population health functions or how these models relate to that? And I've got one more question for us.
Yeah, briefly, I'll just jump in and say, I think the key, the way I think about it is about giving flexibility to the practices, right? So if the practices and clinicians can only fundamentally get paid in a majority way, the majority of the reimbursement is going to come through one vehicle, which is I'm going to do visits, then how are we supposed to care for a population when many people in my panel true story, don't come in for visits, right? So the only way for me to reach those patients is to reach them where they are. And so the goal here is to give flexibility, to give tools, to allow practices then to be able to reach the patients where they are. The ones who are coming in, absolutely, they're going to keep coming in, and that's great. But now we have more tools, and we don't have to worry about, oh, we get paid less for an audio only visit than we do if that patient would just come in. We don't have to worry about that anymore. We're getting paid to take care of the patient where they want to get taken care of, ideally for the best outcome that we can.
All right, rapid fire. I think we've got one more question here, and this is the bottom line that all three of you can give an answer to, because I think this is what we're about, outcomes. If what is effective and fair ways to hold providers, but I would also say for patients, accountable for doing all that care coordination, navigation, care, the care management activities. What is the outcome that you're looking for from providers or for providers? And then what's the outcome you're looking for to know if we're successful, right? To cut to the chase, to know if this is working. What is the outcome or a couple of outcomes you're looking for for you to feel satisfied that this system is delivering the care that's we're looking for?
Well, I can start. I would say that what we look for is how is care management and chronic management, how is the chronic care being managed in a way that's the right care, right setting? We really focus on reducing ER visits and readmissions when appropriate, and ensuring that they get preventative care and or wraparound care after an ED visit or a hospitalization. Ensure that they're having the elements, back to my medical related social service background, way back in the review mirror, we would do discharge planning for chronic care management patients. And inevitably, if we had a care plan with 10 things, only 2 things happen, because there was no one sort of following up and ensuring that care that was needed and those interventions were in place. So what we evaluate is the adoption, motivational interviewing with the patient and the care navigator to ensure that they're engaging in the activity, the resources, and that we're seeing that reflected in our utilization patterns. So I'd say right care, right service, and ensuring that we have the wraparound.
Thank you. How about Christina and then Amal? What's the outcome you're looking for?
Quickly, that patients and their caregivers feel that their conditions are being managed thoughtfully and in a coordinated way.
So I absolutely agree with Melanie and Christina. I think the thing I would add there is also decreased physician burnout, greater provider satisfaction, feeling like, hey, we live in a sustainable model where primary care is appropriately valued and recognized for the health value and the economic value that it creates. And so I think there, if you put it all together, I guess we're going after the quadruple aim.
Yeah,
exactly. That's great. That's
so
good when the world comes back. So Todd, I will turn it back. Thank the panelists for a tremendous conversation. I really appreciate your candor, how we saw from different perspectives and different angles. Thank you for a rich conversation, and I will turn it back to Todd to close us out.
Thank you, Peter.
Yes, thank you, Peter. Thank you, everyone, for joining us for what has been a fantastic conversation this afternoon. I want to thank everyone for tuning in, and I do want to give a reminder that right now the Senate Finance Committee is actually exploring payment reform. So if you have a moment, please go online, submit your comments. We encourage you to provide your thoughts and feedback to the committee, especially because we had some fantastic questions and comments come in today. You can find the link in the chat. As I mentioned at the top of the call, this webinar was recorded and will be available within the next 24 to 48 hours. So please keep an eye on your inboxes. If for any reason you don't hear from us, you can also always find the materials on the PCC website at thepcc.org. So thank you again, and I hope you all have a fantastic afternoon.